lead to key activation of trypsinogen activation and cytokine release, and this finally end up with the leukocyte activation and cytokine release and fibrosis and this pain. And if you have plain X-ray abdomen, very simple investigation, you see the pancreatic calcification here. And obviously, if you do the ERCP, you see the dilated pancreatic ducts and some stones there. And if you take the FNAC, this is the chronic pancreatitis with the shrinkage of the pancreatic part as well as the endocrine part and fibrosis there. And certainly, if the surgeon take it out, this is the morbid anatomy of the pancreas. Next, please. Pathophysiology of pain. What is the concern of the patient? He's not concerned about these complicated pathogenesis, and pathophysiology is concerned about the pain. So the primary duty of the doctor is to relieve the symptoms. I always teach my junior, then medicine, the cure rare, relief often, and comfort always. So here comes the theory of relieving pain. And the patient want to be relieved of his symptom. And it happened because there is elevated interductal pressure here, elevated pancreatic pressure, and pancreatic morphology is like this. Next. Other the neurological reasons, I mean, the here the peripheral nociception, because they are nerve ending and get upregulated and sensitized with different by cytokines. Then there's a pancreatic neuropathy like picture as you see in diabetic neuropathy. So you have a severe agonizing pain sometimes you have a dull continuous pain of involvement of autonomic nerve fiber. The central pain, usually patients have repeated pain, so threshold for the pain is lowered centrally also. So this is something related to the brain. Next please. So another reason for the pain is the complication of pancreatitis, because it never ends, and you can have complication like pseudocysts, duodenal obstruction because of the external pressure, bile duct obstruction, duodenal ulcers, splenic vein thrombosis, as I've alluded in my first slide, the relationship of the vessel with the pancreas, gastroparesis, diabetic neuropathy because patient develop diabetes because of chronic pancreatitis, mesenteric ischemia, and pancreatic cancer. Next. Sometimes it is not the disease which is causing the pain and responsible for the symptoms. It is the treatment we offer, and if this treatment is not appropriate and not well monitored, you can have opiate-induced bowel dysmotility, and I've seen patients who develop intestinal obstruction even in old age because of the opiate use. Bacterial overgrowth, endoscopic complications, and surgical complications. Next. So finally, what are the objective of the therapy? That how to get rid of this pain in chronic pancreatitis. So there's a long-term pain relief, and then you have to improve the quality of life of the patient, because that's the main concern of the patient and concern of a good doctor. Somebody was talking of the good clinical practices, the best clinical practices. So we all forget. We do the endoscopy and send the patient home without discussing the symptoms and disease nature with him, because this is going to improve the quality of life. Maintain the pancreatic functions. Next. So endotherapy, which is my focus today, that how the endoscopy is going to help this patient. So first technique we use is the symptotomy. This is for the papillary sphincter, either biliary, pancreatic, the major papilla, or it is the minor papilla. And then we can do the stent placement because there is obstruction to the pancreatic secretion because of stone and stricture and disruption of the duct. So what happen is the release of the pancreatic juice, pepsinogens, cytokines, they through the auto digestion of the pancreas, and you end up with the auto necrosis of the pancreas. So you have to establish the flow of the pancreatic juice to the duodenum by placing stent. Endoscopic shortwave lithotripsy, if there is stone there, mechanical lithotripsy, Yesterday, somebody asked me when I was yesterday was presenting a case of ERCP, that is this available? I said not available, but we do mechanical lithotripsy in our center, and now we are hoping to have a laser for this. Stone extraction by balloon extraction and stricture dilatation. Next, this is complication actually. So ductal strictures with stone are both sphincter dysfunction. I'm the sphincter of the pancreatic duct opening as well as the biliary sphincter. Pseudocyst and ductal disruption and biliary obstruction. Next, Dr. Yasmin here. That is the huge pancreatic duct because of the obstruction, and we have a stone here. And here you see this basket was put on, and the stone, and this is possible in our center also. Next, next, please. So, what is the evidence? This is the era of evidence-based medicine. Practice on the patient, the right of the patient, and that is the evidence from this published paper from American Journal of Gastroenterology. This is the 4 series analysis, which is showing 187 patients. The immediate pain relief was present in 83 to 90% of the patient. So just you remove the stone, patient will be relieved. So this is the miracle the endoscopy or ERCP can do to diagnosing pain. Long-term pain relief in 54 to 83% of the patient, and this is the follow-up up to 18 to 60 months. Good follow-up for 5 years, and only 5 to 12% people need surgery. The time has gone when people prefer the first stage surgery because these options was not available in Pakistan. These options now very much available in Pakistan, and you left with only 5 to 12% of the patient who need surgery. Rest can be treated with good interventional endoscopy therapy. Next. And this is a structure and stone here. Again, this is how this structure is dealt with. And if structure is not dilated properly or it is a stiff structure, you can put the pancreatic stent here. Next. Surgeons. I always not very popular with the surgeon because I believe the surgery is the failure of the medical science. You don't have to cut the things, you have to correct the things. And as somebody from the NGOs was saying, it is not only treating diseases. There should be preemptive approach to be healthy, stay healthy. That the nutrition people was saying. So I think the approach should be to promote health rather than treat diseases, and that's the reason I have introduced a new society on this planet. And I'm saying planet mean I've traveled all over and talked to the people, and that they are not aware of this society because I'm the only president and office bearer of that society and only member, and that is no disease society. I think the NGOs people can work on that, the people of public health, that you should not make the society just Professor Ajmal is staying here, society of pancreatic diseases, society of liver diseases. You should make it no disease society on this planet. So let's carry on this message forward that you should work for a society, and I need a lot of members here. That no disease society should be promoted. This means actually we are promoting health rather than prevention even. Prevention is a second step. First, I think the nutrition people will be the happiest to me to join this society, that you promote health. You talk of the healthy lifestyles rather than you prevent diseases by vaccination, and then you treat diseases like me as a gastroenterologist by putting endoscopes in the small duct and go to the surgeon to cut their gallbladder, their duct, their pancreas, their appendix, their tonsil, which I call the failure of the medical science. As the science grow, I think people will not go to the surgeon, and surgical specialty will be over, I hope, in next 20 years. Next, bad news for the surgeon. So pancreatic duct disruption. So this is how, if you do the ERCP, this is the pancreatic duct disrupted here, and you can see the dye coming into the parenchyma, and this should be how it normally look like. And these are different way than when these secretions they go out and they produce the pseudocyst. Next. This is very common to the physician, gastroenterologist, and surgeons here, that you see the pseudopancreatic cyst here. Next. So obviously, once you have all these pseudocysts, you have to drain this. The methods are intervention radiology, that you can use the percutaneous methods, which is relatively now out of place. But being gastroenterologist, the endoscopy is the first choice. Again, the surgery is coming down here. You can do obviously now the laparoscopic surgery, or you can use combination of all this. What are the prerequisite? Cross-sectional imaging. What I mean here, a good imaging. Before you put the endoscope in, put the stent in, or you put the needle in, you must be knowing the real anatomy, the other morbid anatomy, the what is the route or tracking you are going, because other you end up with the complications. Uh, the skill intervention, you need a lot of training. And now people must be using the EUS, not only the CT scan. And Alhamdulillah, this is available in our center. And in Northern Punjab, we are the only public sector hospital, even private hospitals don't have this US, because this is very easy to localize the lesion and keeping track, on the procedure. Multidisciplinary approach, you must be ready with the backup. Although I've not give very good remarks to the person. Naeem Taj is also here, but we need you, sir. When we fail, you are the basically our backbone and survival. Next, next, please. So indication for draining, we all know non-infected pseudocyst, gastric outlet obstruction, pressing the distal stomach, biliary obstruction causing jaundice, and rapidly enlarging wall of necrosis. Failure to improve with the conservative therapy and ongoing symptoms. So this is the 8 weeks. Usually you don't put any endoscope or any stent in. You wait for 8 weeks for resolution. Not only for resolution, but a proper organization and walling of phenomena of the cyst, then only you can drain them adequately with the endoscopic procedure. Timing of draining of drainage intervention is very important. Contraindicators: when there is no wall, please do not try to drain. When there is a wall difference between the stomach or the pseudocyst or other cyst is more than 1 centimeter, there is a chance of slipping away of stent. Evidence of pseudoaneurysm, as somebody mentioned before also. Next. So this is the thick wall cyst. So you feel difficulty to going in and putting stent. And this is the endoscopic ultrasound. You can see the varices and other vessels here. If they are present on the way to the cyst, you are causing hemorrhage, so you should be careful. So I think it is much better to do it on EUS guided rather than CT scan. Next. And we all know this is a conventional transmural drainage with the plastic stent. You can see 2 or 3 stents depending upon the size of the cyst. And these are called the pigtail cyst, pigtail plastic stent. Next. And this is same, you can see, you can produce a hole like this, and you can take the all debris out. The necrostectomy, that is called, once you created this hole in the stomach, you can use needle knife or other curettage equipment to take this all debris out, and patient don't have to go to the open abdomen surgery. Next. And this is the metallic stent here. You can put the metallic stent. Next. And this is how we were using the pigtail, and now we're using the metallic stent, ultrasound endoscope guided. And we have done a couple of cases and published the data of when you're putting these stents. And now we have the new stent that the surgeons are aware of. This is called the LAM stent, the lumen imposing stent. Next. And what is the evidence? The metallic better or plastic better? If you see that this is the plastic stent here, double pigtail, the symptom, the drainage, I believe, is 89%. Metallic, fully covered, self-expandable metallics, and 98%. Not much difference. The cost is 4 or 5 times higher here. Next, please. And what about the adverse event? In plastic stent, this is 15%, and it is 8% in fully covered self-expandable metal stent. So here is a gross difference that the complication or adverse events are more with the plastic stent. Next. And in conclusion, the US guided drainage of pseudocyst using fully covered self-expandable metallic stent is safe and effective regarding the drainage of the cyst. Drainage of pseudocyst using metallic stent result in better clinical outcomes, although this is a marginal difference, but lower adverse events. That's the reason in our center we're mostly using metallic stent and asking, and this is a good news for the poor people because this is all free. And metallic stents are even which cost 50,000 rupees to the stent only. They are provided free of the cost. So better than some international hospital. I have with my not father but the mother. Next. So this is the data here, the evidence, the systemic review of 17 studies, 81 patient. The treatment success rate was 81 metallic, 82 plastic, pseudocyst 85, 83, wall of neck 70, 78, adverse event already mentioned, 6%. It is a grass difference here. The recurrence rate is almost equal. So in conclusion, the similar outcome for adverse event in favor of, except adverse event in the metal stent. Next. So these are the latest stent, which is called the lumen opposing lamp stent because they are 1 centimeter. So they oppose the stomach and cyst very closely, and drainage become easy. Complication are less. They can be cold or hot. Next. And these are different types of stent which are now available all over the world. I think we have put the Axius stent, this Axius stent in our center, but we are still in the very naive stage. I hope we will have more experience in future. You can have this Paxis stent and Nagi stent. Next. This is again regarding the stent. Next. Next. So this is the special way of Corlick. David Corlick is our friend. He's from Harvard School of Medicine. Now he's the chief of Cornell University of Manhattan, York Avenue. He devised his own way of drainage, and he is in our center to teach us this method 5 times. That's the reason we have dedicated one room to him, which is called the David Corlick room in Holy Family Hospital. I think that Dr. Naeem and Dr. Yasmin know how this is done under fluoroscope. Next. And this is our humble center. You can see me in the middle, but Professor Bushra here. And our strength is our anesthesia people because, and our histopathologist who do the on-site histopathology. And in 5 minutes, we know that this patient is having malignancy, or so we can put the metallic stent. Or this is a benign thing, so we can put the plastic stent. And again, this is a huge team of 22 fellows there. This is very nearby, and this is one of the state of art center and the biggest center in the country for GI liver diseases, providing free service. I thank you for your patient listening.
Thank you, sir. Accomplishment will prove to be a journey, but not a destination. Now, I would like to invite Dr. Sohaib Huda, Chief Executive Officer, Dr. Saab, for his closing remarks.
Bismillah ar-Rahman ar-Rahim. It is my utmost honor and a great privilege that I got a chance to address this gathering here with the finest names in medicine and surgery have blessed this conference with their presence. I want to officially thank you who participated in the second International Medical Surgical Conference and Expo 2018. I want to congratulate my team, Dr. Shima Baloch, Dr. Bazila Saeed, Ms. Rida Baloch, Faik Baloch, Sayyid Danial Hussain, and Muhammad bin Basir for successful management of the event. I also want to take this opportunity to introduce Dr. Sahab. Dr. Sahab is an initiative. It's a revolutionary web portal and an Android app that is providing medical services, which includes doctors, paramedical staff, physiotherapists at the comfort of your home at extremely affordable rates. It is a conductive medical solution for this day and age of ever evolving challenges and disruption through innovation. I thank you all for being here. Assalamu alaikum.
Now, would like to invite Dr. Shima Baloch, Chief Operating Officer, Dr. Saab, for a word of thanks.
Bismillahir Rahmanir Rahim. Assalamu alaikum. Ladies and gentlemen, distinguished guests, my dear teachers, and everyone. Thank you so much for being here. Thank you so much for 2 extraordinary days. Thank you so much for taking out time for these wonderful lectures. Thank you so much for sharing all this knowledge with us. I would especially exclusively like to extend my thank you to the Vice Chancellor, Rawalpindi Medical University, Dr. Umar, for taking out time on 2 consecutive days, yesterday for the ERCP live and today for being here with us for the lecture. I would also like to thank Dr. Naeem Taj exclusively for the live bariatric surgery, extraordinary procedure, flawlessly done, live streamed from CDA Hospital, and then being here for the live discussions. I would also like to thank Dr. Ajmal Saab for telling us that cleft lip is no more an issue, and all we need to do is redirect people to him who we know need his help. Thank you so much, everyone. I would also like to extend my gratitude to the Society of Surgeons. Dr. Naim Zia, he is not here, the president, but it would not have been possible to make this event happen the way it has. Thank you so much, dear seniors, for being there. I would love to thank all the organizing team, especially our management team, all for one, being run by Mohammed bin Basir, for his exclusive courtesy for 2 days. I would like to thank Leander Films, Sayed Taki Shah, for extraordinary streaming that was not just run from the venue of ERCP and live surgery at CDA Hospital and Holy Family to the venue, but it was exclusively streamed live at all other cities that we could reach in Pakistan, and the stream was sent all across the country. Dr. Matiur Rahman, thank you so much, sir, for your kind words. Your encouragement was of a very different level, of a very different magnitude. Had not been for you, things might have been a little different for us. Thank you for your very, very kind support, very kind encouragement for being there with us 2 days and even bearing with us for the slight delays. Dr. Omar Saab, sir, you were right in saying that it was a very scholarly gathering. It was very different. For a change, we wanted to bring surgery, medicine, and every aspect of medical study together. And Alhamdulillah, very happily, I would like to say that we have been successful in doing it. We brought live ERCP, we did the live bariatric surgery, we got nutrition, we got ENT, we got eye, we got rheumatology, we got cardiology, we got oncology, a huge session yesterday. We got Islamabad and Pindis, two biggest labs to be here with us for 2 long days. मुख्तसर बात ये है कि ये इवेंट ऐसा ना होता अगर आप लोगों का सपोर्ट ना होता, क्योंकि हमने 2 बंदों से शुरू किया था, मैं और सुहेब. इट वाज बेसिकली अ ड्रीम, अ विजन, बट ये विजन यहाँ तक सिर्फ उस सूरत में पहुंचा जब हमारे साथ हमारे अपने लोग मिले. डॉक्टर बाजीला, रिदा, फाइक, सैयद दानियाल शाह साहब वहाँ पे बैठे होंगे. एंड देन मोस्ट इम्पॉर्टेंटली आई वुड लाइक, ओके काफ़ी पीछे बैठे हुए हैं, लेकिन इफ दे यू पीपल कैन टर्न एंड हैव अ लुक एट दीज गाइज, because I want you to meet them, the IT and the tech team behind this. Hassan, Waqas, Humail, Hussein, जितने भी ग्राफिक डिजाइनिंग की कलर्स की ब्लेंडिंग स्कीमिंग एंड दिस ऐप, these boys, they are graduation students and still studying, and they've done it. They've done it. We have done it, but Thank you so much, everyone, for being there, for the support you are. My mom's here, Soheb's mom and dad are here. Thank you so much. You people, we love you. Couldn't have been so without you all. Thank you so much, everyone. And now I'd request Dr. Umar Saab to please come on the stage. और वो शील्ड्स की डिस्ट्रीब्यूशन में हमारे साथ हैं एंड डॉक्टर नईम साहब वीड लाइक टू हैव अ क्लोजिंग नोट फ्रॉम यू एज वेल एंड वी हैव जस्ट बीन जॉइंड बाय डॉक्टर नईम ज़िया साहब एज वेल sir thank you so much for being here again and we'd like a closing note from you as well thank you so much sir please thank you everyone.
Thank you very much, Dr. Shima. It is a privilege and honor and to be here and to be part of this conference. Dr. Shima came to me 2 months ago and says that I'm going to conduct a health expo and conference. I was surprised and looked at her, are you serious? He said, oh, yes, I am going to do it. I told her that when we conduct a conference, we as a Society of Surgeons, 15 to 20 departments, they work together day and night. Then we used to conduct a conference. He said that, oh, yeah, I will do it. And Zoeb and everyone was with him. And I was surprised that she conducted an extremely well conference, and it was a great success. Hats off to you, Dr. Shima. I'm extremely thankful to all the participants who participated in, especially Professor Umar, the Vice Chancellor of RMU. I know how important job it is, how busy a person is. It's very difficult to spare time. But just for the reason that it was an academic event, so he participated wholeheartedly for 2 days. Even he came today on Sunday also. He has a busy schedule, and it was wonderful to see him doing the live endoscopic workshop. And mostly the surgeons, the endoscopic persons, they used to bail us out when we struck in case of some gallbladders and there's some fistulas or there's some stone in the CPD. And the patients are complaining, doctors, we are still having the same complaint, what you have done with us. So we took the gallbladder out. This is the specimen, everything is there. No, pain is there. So at time, there's 2% chances of stone in the common bile duct at the time of surgery, which is missed by the ultrasonologist. So they used to bail us out, and they took this stone out and make our life easier. Thank you, sir, for doing all this thing. Extremely thankful to Professor Naeem Zia, the President of Society of Surgeons, participating in this conference for the 2 days and chairing this session of bariatric surgery. Extremely thankful to Professor Ajmal, oncologist, ENT specialist, Tausif Amin. And in the end, I'm extremely thankful to my Capital Hospital Surgery Department, Dr. Kirtala Perwani, the anesthetiist, head of anesthesia. So he gave anesthesia on Saturday around 12 after 12. You know, on weekend, the staff, they don't stay so much. And after 12, they get arrhythmias to go back home. So he was very helpful. He did it very well. I'm extremely thankful. The successful person behind the camera person of my bariatric surgery was my wife. तो जो बेगम अपने खामद पे जो नजर रखती है ना, उससे बेहतर कोई नहीं नजर रख सकता. तो उन्होंने जहां भी मैंने मूव करना था, extremely thankful to Dr. Zakia, and thank you very much. Thank you. So nice of you.
Thank you, sir. Now I would like to invite Dr. Naeem Zia for closing speech.
Thank you very much, Honorable Professor Muhammad Umar, Professor Ajmal, Dr. Zaid Manas, respected Dr. Naeem Taj, Dr. Shima, and I can see my friends, old friends, Dr. Raza Shabir and Dr. Anjum, yes. So they are my old colleagues. We had good times in Holy Family Hospital. So it's an honor to be here. As I said yesterday, that conferences go a long way in transferring knowledge. As we are aware that the data is so much that one cannot cope with them. So the only way to learn is to attend these conferences. But I always stress that it's very upsetting for me, as a matter of fact, that the attendance in these conferences are very, very low. Appreciated the steps taken by PMDC to get all these conferences accredited by CME points so that all the doctors should attend it. But hats off to all the participants who participated in this workshop and conference for on the weekend. And I wish all the best to Dr. Shima for launching of this app. And I hope this will go a long way promoting the health culture. Thank you very much.
Now would Dr. Mohammad Umar to present shields to the participants. Dr. Matiur Rahman. Thank you, sir. Dr. Naeem Zia. Dr. Naeem Taj. Dr. Zakia Naeem. Dr. KL Parvani. Professor Dr. Muhammad Ashraf. Dr. Yasmin Iqbal.
Thank you for giving me this shield. I made only announcements, not the presentation. Nevertheless, thank you very much.
Thank you, sir. Dr. Salim Chauhan. Dr. Noshin Abbas. Dr. Sadia. Dr. Tahir. Mohammed.
And shields for our team. Dr. Bazila Said, please. Quick switch. Co-dukes, can we have you over, please? Come, quick. Quickly, boys. Bazila, your dedication. Thank you. Yes. Co-dukes, sir, IT and graphics. Sara, इन्होंने किया. Sayyid Taki Shah, Lianda Films. Thank you, Taki Bhai, for uninterrupted, beautiful streaming for 2 days. And Mohammed bin Basir, where is he? The management person. All for one. Okay, Osama, you can collect it on his behalf. Please. And yes, Tabe Bhai is not here. Sayyid Tabe Hamdani, he was yesterday. Thank you so much, Tabe Bhai. Can someone please collect it on his behalf as well? So if you can get yours as well. And thank you, everyone.
Dr. Seema Baloch. And ISMC team to present shield to Dr. Umar. I would request Dr. Muhammad Umar as chief guest of today's event to give some words about thanking closing ceremony.
Thank you very much. I think the only thing which this young team, this young blood, the way of working, their humbleness and politeness, and well aware of the IT technology. I also thankful to all the participants and elegant speakers, and my friend Dr. Naeem Zia and Professor Naeem Taj, Professor Mateen Ajmal Saab, and many other friends sitting here. Only I can say, हम तो चिरागे अव्वल शब हैं. This is for the organizing team. हम तो चिरागे अव्वल शब हैं, अव्वल शब बुझ जाएंगे. तुम तो चिरागे आखिर शब हो, दीप से दीप जलाए रखना. Thank you very much.